Good afternoon, everybody, ladies and gentlemen. My name is Emad Saweeres. I'm one of the orthopedic doctors in Egypt, and I'm the secretary of the Scientific Council of the Arab Board. I wish to welcome you all if you're coming to the exam next to Cairo. Uh, the venue has been decided. The dates have been decided earlier on, but due to the current circumstances, we are rescheduling them. So I'm not free to give you the dates, although we're working on that. Um, Probably in the next couple of days, you'll get the advertisement to tell you when the exact dates are. But I would want to stress that in Cairo, we are welcoming you as friends. We are not just examiners. We are here to serve both the examiners who come to examine you and the candidates. And if you find any difficulties, you're very welcome to come back to us. During the past few years, I haven't included 2023, but the numbers of candidates have been increasing from the first time we started the exam in Egypt, where we had 4 days and 5 examiners. Up to now, we've got something like 25 examiners examining 72. Next exam will be 88 candidates. So those who are coming for the exam as examiners, make sure you've got a very big work for yourselves. The setup is like that. We have cubicles. It doesn't have to be the same photo because we are looking at a different venue now, but the setup is the same. A cubicle with a certain number of examiners with the beds for examination. The tools are provided, like hammer, measuring tape, or goniometer. They are provided. You're free to bring your own, but we are providing most of the things. The examiners have a screen with a computer, or maybe an iPad now in the next time, and they will be marking you according to your performance. When you come to the exam, you'll be given some stickers with names on your names and numbers. So it makes life easier. Instead of introductions as you get into the cubicle, you just hand the stickers to the examiner. They use them for identification, and you do not have to go into the niceties of, hello, I am doctor for so and so, or whatever you want. The results used to be on an Excel spreadsheet. Nowadays, if we use the computerized system, we don't need that. Before you start the exam, you have to make sure that you come in the exact time. We will be advertising the timings, and anybody who comes later than a certain cutoff point will not be accepted into the exam. Don't say I got stuck in the traffic, whatever. You make sure that you come on time. You plan your journey early. There is no point in coming late and saying, I'm sorry. Once you register at the desk, you will be given your stickers that you will use throughout. You will hand off your mobile phones as well as any, I would say the watches, the Apple Watches, the iPads, whatever, anything which can communicate with the outside world. So you'll be put in a prison, just to frankly speak. You only have your books. I know that some people used to read from the PDFs on the iPads, but we cannot allow them, I'm afraid. So once you report to the exam venue, all these things will be confiscated. They will be kept safe and handed to you later on. And nobody will be leaving the exam venue until everybody has finished their exam. I usually have an orientation at the beginning and a feedback at the end. The examiners always have their orientation as well, especially when we introduce this new system. Now, the exam is composed of 3 parts, and you have to pass each one of the 3 parts in order to get your certificate and the qualification. So it's OSCE or short cases. They usually are 6 stations. Don't take me or don't hold me accountable on these numbers because they can always change. But the usual thing is 6 stations. Each one is 5 minutes. 5 minutes for the task plus 1 or 2 minutes for changeover and marking. So you've got 5 minutes, and the station is already manned by 1 or 2 examiners. The examiners have got a checklist where they record every step that you do. there is usually very little interaction between you and the examiner. You're allowed to do the examination or whatever, and they only watch you and mark you. Some stations will have interaction with the faculty, so be flexible and ready to interact. Don't be taken back. So if you start at the station number 2, for example, you'll go around the circuit and finish at number 1. If you start at number 5, you'll go around the circuit and then finish with number 4. So each person will have to do this exactly the same stations as the other people. The stations are either history taking or examination. And I will cover the history taking now instead of covering it in the intermediate case, so you will all know what to do. It's like when you were doing that in medical school. I'm sorry to say, people, when they grow up, they learn to cut short corners. There is no harm in cutting short corners as long as you know why you cut it. But most of the time, you need to get as much information, especially as much relevant information from the patient, in order to, 1, make the diagnosis, 2, to explore the functional implications of this disease condition, and 3, to plan your investigation and management. So if, for example, the patient is being treated for diabetes or hypertension or having anticoagulants, you have to know that for the planning of the management, it doesn't affect your diagnosis, but then you have to keep all these in your mind. History is usually the age. Hello, what's your name? How old are you? What do you do for a living? Sex, you don't have to ask most of the time. And the marital status is sometimes irrelevant. The presenting complaint is the main problem, or the main cornerstone. You would want to know what brought this patient in. And some patients come with multiple complaints. What is the most important thing that you are concerned with that brought you in? And then he would say, it's my back, and you'll forget about his knee, which is arthritic anyway, because this is not the point. And if the examiner finds that you are going along a wrong track, he will probably prompt you to go into the correct track. So if the examiner interacts with you, don't take that as an insult. He's not trying to deceive you. He's not trying to trick you. He's only trying to put you back on track. And the complaint has to be analyzed in this sequence: onset, course, and duration. So I'll say it in Arabic. ابتدى امتى؟ ابتدى ازاي؟ وقعت اتخبطت اتلويت ولا ابتدى لوحده؟ ودلوقتي احسن ولا من 6 شهور احسن ولا زي ما هو؟ يبقى you know if it's getting better, worse, or the same, and you know how did it start and for how long. Then we analyze the complaint and go into the present condition. Most of the time in orthopedics, they come with pain. And for pain, it doesn't have to be just pain. They sometimes give you the character of the pain, which doesn't help you very much. بيحرق ومش عارف بيغزني that doesn't matter very much. What we are interested usually in is the pain distribution, especially if it's something which can radiate somewhere else. So if somebody comes with a leg pain, you would want to know if they've got back pain. If they've got back pain, you want to know if there's leg radiation or not. If they come with a knee pain, you'd ask for about groin pain maybe, or if they can reach their toes to know if the hip is all right or not. So just make sure that you know where the pain starts, where it does it go. And then, does it wake him up from sleep? That's night pain. And when he wakes up in the morning, how does it feel, if it's any better or worse than the rest of the day? What aggravates and what relieves your pain? And that would tell you if it's mechanical, if it's there all the time, if it's a startup pain and then gets better as he walks, if it's a plantar fasciitis, for example, which hurts on the first couple of steps and then gets better. That's all. Associated symptoms is, for example, pain in a knee. You would want to know if there is swelling, locking, or giving way. That's most of the time is what you're interested in. And if it's a back pain, you'd want to know if it's radiating somewhere else. If it's radiating to the lower limbs, you'd want to know where does it finish, so that you'd probably have an idea which route is affected. And then other systems sometimes are relevant. So you'd want to know if the pain increases going up this hill or upstairs, or downhill or downstairs, in order to differentiate spinal claudication from vascular claudication. Does the foot or the leg change color or get cold or warm at stages? And what does it stop you doing? How does it affect your function? Remember, somebody who's very young playing basketball for his college is different from somebody like me who only goes to his clinic and comes back. You wouldn't want to do a meniscal repair or a meniscectomy on me with my degenerate meniscus. But somebody who's got an ACL and a locked knee, for example, then that's maybe an absolute indication to do an ACL reconstruction, for example. And then what treatment modalities has he attempted? Did he try anything? Did he get an X-ray? Did he have a biopsy? Did they operate on it before? Did he have medications? Finally, the past history, which includes 3 points. One is medical conditions. بتتعالج من حاجة تانية، سكر، ضغط، أسمة، أو أي حاجة تانية. وساعات يقول لك انا ما بعالجش بالسكر بس هو عنده الضغط، فلازم تاكد anything else. Every time he says something حاجه تانية في حاجه تانية، خلاص كده انتهينا. Any previous operations, where it doesn't have to be an orthopedic operation. It could be something else. Somebody who's had panhysterectomy or had an operation for a malignancy, for example, is important. And then drug allergies, which is most importantly drug allergies, so you don't give him something that causes allergy. So this is, for example, that could be an OSCE station on its own, history taking, or it could be a part of your intermediate case. And I will come back to the intermediate case later on. Clinical examination OSCE stations are usually structured with minimal assessor interaction. It's usually a real patient. Very rarely we use actors, but the actors will know exactly what to do. But most of the time it is real patient. Always make sure when you're dealing with a real patient, or even with an actor, that you don't hurt the patient. The niceties are important, or the formalities, like I'm Dr. Emad, I'm one of the orthopedic doctors. Can I have a look at your leg? What brought you? Something like that. And always be courteous to your patient. In the OSCE, it's 5 minutes, so it's usually a specific task. So he will ask you either to examine a certain joint, examine ligaments of a certain joint, examine range of motion, examine leg length difference, examine, I wouldn't ask you to examine the whole hip, for example, because I wouldn't expect you to finish that in 5 minutes, but I can expect you to measure leg length, for example, in 5 minutes. That's not difficult. The performance areas are how can you communicate with the patient and conduct the exam? Do you use the time efficiently, or are you just not aware that the exam finishes in 5, or the station finishes in 5 minutes? And then the appropriateness and fluency of your exam technique. Remember, OSCE is about examination or short case. It's not about history. Most of the time, the instructions on the outside of the cubicle will tell you, this patient is so and so years old, whatever number, n years old. He's complaining of whatever, and there is no history to take. So you don't need to take history, for example, when the station tells you to do an examination. And if the examination is, for example, examine the range of motion of the shoulder, then you have to do active, passive, and compare both sides. And you can do both sides together. You don't have to say, lift your right arm, he's got 160 degrees of abduction, and then left your left arm. Don't waste your time. You can sometimes do things together. If the station is too long, or the time is too long for the task that you're given, it means that you have to do it more carefully, like measure angles, for example, with a goniometer. If the time is just enough for you to do that roughly, when you say restricted range of motion, that doesn't help me at all. What I want to do is, for example, a patient standing with a 10 degrees flexion deformity. If I measure it and it turns out to be 12, it doesn't matter. So give a rough idea about the range of motion. And remember, this is 180, this is 90. Anything less than that, a little bit, 1/3 the way down is 60, and then half the way down is 45. So roughly you can tell what is the amount of deformity and what is the range of motion. And remember, the patients we examine normally in a systematic way, we examine them standing, and you go, instead of going around the patient, you can ask the patient to turn around. So if I'm standing in front of you, I can turn to one side and then to the back, and while you are staying on the same side of the patient. And if you see the patient from the front, the examiner will be seeing him from the back, so he will have a different view. But when you turn him around, the examiner will be able to see him from the front, and you will be able to see him from the back. So standing, walking, on the couch, either sitting and then lying down. Remember, look, feel, move, special tests. With any examination on the standing position, remember deformity, skin contours. So we are not concerned with dilated veins or pigmentation unless it is relevant. But if you miss a deformity which is obvious, somebody standing with a varus deformity of his knee, then and you keep on describing hair loss and trophic change, oh, that's not very relevant. So deformity, and then skin, whether it is pigmented, whatever. I've got a scar. Scars are very important, and how did they heal? Always describe that. And remember, if you've got a swelling, there is a way to describe any swelling: side surface, consistency, movement with moving with pressure, and fluctuation. So always go back to the basic principles, and you'll be able to finish your exam in time, and you'll be able to do it very consistently. Practice that with your colleagues in the clinic. Take one of your colleagues who is doing the exam and say, watch me while I'm doing the exam, comment on my performance, and I will do that for you. So at least you practice how to finish that in 5 minutes. So standing, sitting, standing, walking, sitting, and then lying down, look, feel, move, special tests. The intermediate case station is a 20 minutes station. Actually, in the FRCS, trauma and orthopedics is 15 minutes. So we're giving you enough time to finish your exam. So it is a history, clinical examination, discussion, which means that you have to finish all of these, each one of them in 5 minutes. So brief history in 5 minutes, focused, brief clinical examination, and then the examiner will discuss with you maybe in 10 minutes. There will be one patient in each cubicle. So you've got two examiners. Each one of them gives you a mark. So you've got a mark from the examiner A and a mark from examiner B. And then you go into the next station and you have another patient with a different pathology, which means that you can compensate for something that you are not good at in one station by having another pathology that you can comment on. So if I'm not good in spine, for example, I've got another case with an upper limb pathology. So at least I can compensate that. So exactly the same in patient number 2, there will be examiners C and D. So you've got 4 marks, one from each examiner, which means that nobody could argue that we are mistreating you or giving you wrong marks, or Mr. So-and-so is very difficult in his examination. Mr. So-and-so who is difficult has got Mr. the other person who is a little bit easier. So if you get low mark in one from one examiner, you get a better one from the other. And then you've got another chance to compensate for that. You've got 6 chances in your OSCE, and then we'll go for the next. The intermediate case station is marked by your communication and conduct of the examination. Remember, communication and conduct, like spending 5 minutes introducing yourself and rubbing your hand with alcohol, does give you a little bit of mark, but not very much. It's like نمرة الخط في الورقة بتاعتك. لما بتقول أنا خطي كان كويس، ممكن يعني أديك نمرة زيادة ولا 2، لكن مش هديك نمر كتير. Don't waste the time in the niceties, like, and go on for history taking and physical examination and discussion. Each one of them takes the same weight in the marking scheme. So history equals 1/3 of the station. His clinical physical examination is the next third, and discussion is the third. Which means that if you take a good history but do a lousy clinical examination, you lose marks there. And if you take not a very good history, but do a very good clinical examination, you'll compensate for your not very good history. Discussion is like that. You summarize your findings. When you summarize your findings, do give him the positive findings and the relative negatives. So it's a summary. Don't go through all of the questions or the findings that you got, but say what is important and what is relevant. And then the examiner will ask you to give you a provisional diagnosis and a list of differential diagnoses. Remember, with the differential diagnosis, with the investigations, and with the treatment plan, always start in a logical way. So what is common is common. Don't say it is something like a Maffucci syndrome when you've got evidence that this patient has got, for example, an osteochondroma. It doesn't make sense. So when you are giving the differential diagnosis, give them most likely and then the next most likely. Make that sequence, because remember, if you mention the rare condition first, the examiner might catch you then, especially if he's being bored by your clinical examination and the history, and then he will go on insisting on you describing the pathology of whatever rare condition that you mentioned first. So don't dig your own hole. Make sure that you run the examination. Don't let the examiner run it. And don't tell the examiners I'm telling you that. But it's if you are in control, if you steer your driving or steering wheel very well, then the examiner will be just watching you and marking you. Otherwise, then you'll probably not reach the end of the examination. Investigations as well. Remember, it's laboratory and radiological, and then other investigations. Start with the easiest, the less invasive modalities, and the cheapest, and the one which will give you the diagnosis straightforward. So if the investigation is not relevant, don't mention it. If it is invasive, no, start with the easy and non-invasive and then go for the rest. Treatment plan is usually the non-surgical and surgical. And remember, don't dwell very much on the non-surgical because it's an orthopedic exam. We want to know what operation do you want to do for this patient, and then go into the details of the operation and the complications of the operation, blah, blah, blah. So you'd want to cut the story short and reach the stage where you describe, for example, the operation and its complications. One nice resource that you can use, it is an online course that has been run for the FRCS Trauma and Orthopedics by what is called Orthopaedic Academy. This is available on YouTube. And the fact is, I will probably have to stop the sound, otherwise it will disrupt us. So what we did is we have the candidates practicing online, and we give them the scenario, like this is Mrs. So-and-so who has got a college student, right knee buckled underneath her when she was going down the stairs, pain and swelling. And then the candidate will keep asking the examiner as if the examiner is the patient, and he would give him the history, and then we'll show him pictures of the clinical picture of the patient, and then the tests, and then you have to describe whether these tests were positive or negative, and describe how to do the test. In our exam, it's a real patient, so you will have to do the test and describe the findings. Remember, you describe. When you're examining, if a patient is standing in front of me, I would say this patient is standing with a difference, pelvic obliquity. The left leg is got a flexion attitude, and then you ask the patient to straighten it, for example, and say it doesn't straighten, so it's probably a fixed flexion deformity, and then describe what you can see. But then keep on doing that as you examine, and this needs practice. So you don't just stand in front of the patient and look at him, and then turn around, and the examiner will be bored. What are you doing? You have to describe the findings. The way you do the examination is obvious for the examiner. He can tell whether you're doing it correctly or not. So don't keep on saying, I'm putting my hand on this area and then putting my leg on whatever. No, do the examination, and then describe the findings, and remember not to hurt the patient. If you want to have a look at this video, you can scan the QR code, which is on the screen, and this will take you to the YouTube video, which is where this is posted. But then remember, this is an artificial way of doing it, because we were in the time of the COVID-19 and we could not communicate directly. But in our case, we already have real patients, and you're going to put your hands on them and show the examiners that you can do the examination correctly. Next part of the exam is Viva stations, and Viva is 2 parts. So you've got OSCE, intermediate case, Viva or Orthopaedics, and Viva Trauma. Each Viva station has got 2 examiners, and each one of them gives you a mark, because each one of them will ask you in sequence. So it's 25 minutes station, 12 marks, 12 minutes for each examiner, and then 2 minutes to take your breath and catch your breath and go for the next station. It's usually one Viva. The Viva is divided into orthopedics and trauma, and each Viva station is staffed by an examiner. So you get 4 marks for the Viva, 2 for the orthopedics and 2 for the trauma. For the Viva station, we aim to ask you about at least 3 topics, or maybe 2 or 3 topics. The idea is, if you're not as good in oncology, then you probably have a chance to compensate in a different area of the orthopedic curriculum, and so on. The questions are recorded on the iPad or the computer, and they gradually increase in difficulty. Like introductory question, and then introductory question is usually describe this X-ray and what you find on it, or describe the photograph, and then a focus question, which is the main meat of the question. And this is what everybody has to know in order to pass this exam. Competence question is for those who are achieving higher marks, and then the escape question in order to get out of it in a nice way. A general advice is demonstrate that you know the art of orthopedic medicines as well as the science. We are not interested in you describing the classification, which has got 15 points. No, if you've got an X-ray in front of you and he asks you what stage is that, then you describe this patient in particular. If you need more information, say I need more information to stage or to classify. But generally speaking, he will ask you only things which he can get from this X-ray. So make sure that you're describing what you do for this patient. What does this patient have? Do not present for the exam if you do not believe that you are ready for that. And if questions seems to be getting harder, don't panic. It means that the examiner is trying to test your limits of knowledge. He might get harder if you're doing very, very well. So he wants to know how far can you stand in front, or how far can you answer. The thing is, or the other thing is, if he tries to prompt you, like, are you sure? What about whatever? Make sure that you stop and think. Don't dismiss his words, because most of the time he's trying to direct you into a different direction because you've gone in a different way. Dealing with the examiners, always engage the examiners in the discussion. Discuss with or give your orders to the patient, and then tell the examiner what are the findings. Say I don't know if you don't know. Or the other way to go around it is, if something you don't know, you can say, I'm not sure, but from basic principles, I think it could be whatever. So at least you show that you are honest. You don't just make it up. The worst thing you can do, for example, is make up clinical findings because you think the patient has got this diagnosis, while the finding does not fit the patient. The examiner will stop you. He will definitely argue with you, and you will not be in a good position. Be well presented. The presentation is important, and I will tell you later on, whoever comes to the exam, about 2 people who have affected my presentation style. If you have omitted something, say so. For example, if he says, did you ask about his marital status? Don't make it up. Say, sorry, I missed that. Or if you are asked about whether he's got a swelling or not, did he have a previous operation on this leg or not? and you forgot to ask about it, say so. Say, I forgot to ask about that. Listen carefully to the examiners because they are always trying to help you. For the clinical and probably for the Viva, it is a test of your clinical ability and not solely your knowledge. Clinical ability and your intellectual abilities. How are you going to think? And that's why we kept the Viva and not omitted it. Present the positive findings and the pertinent negatives. Make sure that you are competent in all aspects of clinical examination. And with this, I will stop.